Welcome and thank you for standing by. At this time, all participants are in a listen-only mode until the question and answer session of the call. To ask a question during that time, please press star then 1. Today's conference is being recorded. If you have any objections, you may disconnect at this time. Now I'd like to turn over the meeting to Lauren Sokowski. You may begin.
Great, thank you. Good afternoon, and thank you for joining us today for the Administration for Community Living's Targeted Technical Assistance Webinar, Home and Community-Based Services Brokerage Guide. I am Lauren Sokowski, as the operator mentioned, with ACL, and I will be facilitating the webinar. For our webinar today, we have invited Brenda Schmittenhenner and Renee Sherrill with the County of San Diego Aging and Independent Services to present on the Home and Community-Based Services Design Guide, a roadmap for establishing a brokerage for home and community-based services. So before we begin with our presentations, I do have a few housekeeping announcements that I would like to go through. If you have not done so yet, please use the link included in your calendar appointment to get on to WebEx so that you can not only follow along with the slides as we go through them, but also to ask your questions when you have them through the chat function. If you don't have access to the link that we emailed you, you can also go to www.webex.com, click on the Attend a Meeting button at the top of the page, and then enter the meeting number, which is 668-385-454. That meeting number again is 668-385-454. If you have any problems getting into WebEx, you can call the WebEx Technical Support, and that number is 1-866-569-3239. Again, that's 1-866-569-3239. As the operator mentioned, all of our participants are in listen-only mode. However, we do welcome your questions throughout the course of the webinar, and there are two ways that you can ask your questions, one of which through the web using the chat function in WebEx. You can enter your questions, and we will sort through them and answer them as best we can when we take a break after the speaker presentation. And in addition to the chat function, after the speakers wrap up, we will offer you a chance to ask your question through the audio line. When that time comes, the operator will give us instructions as to how to queue up to ask your questions. If there are any questions that we cannot get answered during the course of the webinar, we will be sure to follow up to get them answered. If you think of any questions after the webinar, please feel free to email them to me, and I'm going to enter my email address up here in the chat box located on the screen throughout the webinar. As the operator mentioned, we are recording the webinar, and we will be posting the recording, the slides, as well as a transcript on the ACL website, as well as on N4A's MLTSS network site. I will enter all of these, the ACL website, the N4A website, as well as my email address into the chat box for your reference. So with that, I would like to introduce our speakers, starting with Brenda Schmittenhenner. Brenda is an Aging Program Administrator for the County of San Diego's Aging and Independent Services and Program Manager for the Long-Term Care Integration Project. She has provided administrative and supportive services to older adults and people with disabilities in the private, nonprofit, and public sectors for over 30 years. Brenda is the program administrator for the largest community-based care transitions program in the country. That is San Diego's Aging and Disability Resource Connection Team San Diego. Brenda has served as a liaison between AIS and the Healthy San Diego Managed Care Health Plan since April 2011. And she is the county's lead for the implementation of the Coordinated Care Initiative, which is California's dual eligible demonstration. And also with us today is Renee Sherrill. Renee is experienced in large-scale program development and project management. She has worked for the county's Health and Human Services Agency, HHSA, for over 20 years, and she has led the development and implementation of numerous new initiatives, including HHSA's Continuity of Operations Emergency Management Program, HHSA's Management Controls Initiative, and the Mobilizing for Action Through Planning and Partnerships Community Initiative for HHSA's 6 regions for public health accreditation. So thank you so much to Brenda and Renee for being with us today, and we're very much looking forward to your presentation. So Brenda, with that, I will turn it over to you.
Thanks so much, Lauren. We really appreciate the opportunity and invitation from the Administration on Community Living to participate in today's webinar. You see, we really welcome the opportunity to share with you how our organization, Aging and Independent Services, or AIS as we are more commonly known, and our community of healthcare and long-term services and support providers in San Diego County, California, are really innovating to respond to this new world of rapidly changing service delivery and accountability. After providing you with a brief overview of AIS, I'd like to talk about how we led an initiative to produce a home and community-based services brokerage guide. We're going to walk you through the guide, and then we'll be available to answer any questions that you may have. Next slide, please. Just a little bit about Aging and Independent Services. We are the Area Agency on Aging for San Diego County. We're a core partner in San Diego County's Aging and Disability Resource Connection, or ADRC. But we're also the county's umbrella agency under Health and Human Services for more than 30 different programs and services for older adults and people with disabilities. And so we provide services in a variety of ways. For example, we contract for services under the Older Americans Act, like home-delivered meals and congregate meals, legal assistance, and caregiver support. We directly provide services through programs like Adult Protective Services, in-home supportive services, the Long-Term Care Ombudsman Program. We have 3 different case management programs and veteran services under our agency. We do focus heavily on health prevention programs as well as health improvement programs. We offer care transition support, evidence-based care transitions and self-management programs, as well as fall prevention. We serve all of San Diego County, and all of our services are free to eligible individuals. Next slide, please. For years, AIS has grappled with the fact that healthcare and long-term services and supports operate in 2 very distinct systems of care. They each conduct an assessment, each have their own care plan, and what's resulted is these siloed delivery systems that have proven to demonstrate a system of uncoordinated care with lots of service gaps and duplications and inefficiencies in service delivery. Now, unfortunately, this doesn't come as any surprise to any of you, but these 2 systems, they speak different language. They have different cultures, different financing structures, and different priorities. The result is that the older adults and persons with disabilities are subjected to this fragmented delivery system that it's completely impossible for them to navigate. And this system produces poor health outcomes, escalating health care costs, and most importantly, it doesn't prioritize the needs and preferences of the individual. Next slide, please. So here at AIS, we've long envisioned a new care delivery system that really is person-centered and really does coordinate care across the continuum. A system that eliminates the complexity and the fragmentation that our clients are subjected to, and that supports living in the manner and the setting of their choosing. Next slide, please. So to realize our vision, in 1999, AIS began engaging stakeholders in designing a person-centered, coordinated system of care by establishing the Long-Term Care Integration Project. Healthcare providers, including managed care health plans, hospitals, and physicians, they've been key stakeholders in this process for the past 15 years. Now today, that stakeholder group has grown to over 800, and it includes consumers and caregivers, as well as healthcare, social service providers, and local, state, and national policy leaders. Early on in the project, we established the strategies for getting to this new system of care. We established an Aging and Disability Resource Connection. We developed Team San Diego to create virtual teams around individuals with multiple chronic conditions. And we have supported the Coordinated Care Initiative, or CCI, which is California's dual eligible demonstration. Next slide. Now, through the Long-Term Care Integration Project, AIS has partnered with healthcare providers to build that new delivery system. For example, in 2012, we were awarded the largest community-based care transitions program in the country. We partner with 13 hospitals in 4 large health systems, and we administer a program that targets over 1,700 high-risk fee-for-service Medicare patients each month to receive both hospital-based and community-based supports to reduce their risk for readmission. And you see here what that program looks like. And it may look quite complex, but when you drill down to the program, it really isn't. You see, patients are assessed for risk for readmission, and then they receive specialized nursing and pharmacy services during their hospital stay, and then they are referred to AIS for coaching to activate health self-management and to a program that provides intense short-term care coordination and long-term services and support. Next slide, please. Now, that community-based care transition program has been really tremendously successful in reducing readmission rates. And we attribute a good part of that success to our role in providing the Care Enhancement Program. This program provides intense short-term care coordination, links these high-risk patients to home and community-based services for long-term solutions, and purchases services within the first 7 days after discharge to ensure that those services are in place until long-term solutions can be set into motion. Now, this program has really demonstrated to our healthcare community the importance of long-term services and supports. As a matter of fact, if it were up to our 13 hospitals, they would refer every medically and socially complex patient in their hospital to us. Next slide, please. Another opportunity for partnership for AIS has been the opportunity to participate and partner with managed health plans under the new California demonstration, the Coordinated Care Initiative. In San Diego County, we have about 120,000 dual-eligible beneficiaries and Medi-Cal beneficiaries that are enrolling in 5 managed care health plans. We've established a strong working relationship with these plans for the past 15 years, and when it was time to establish an advisory committee for CCI, the plans asked that that advisory committee and communication work group be established under the Long-Term Care Integration Project. Next slide, please. So under this Coordinated Care Initiative, what's unique to California is that there are 4 community-based long-term services and supports that have become managed health plan benefits. for Medi-Cal beneficiaries and dual eligibles participating in a program called CalMedi Connect. Those 4 long-term services and supports that have been managed in the community previously are now being managed by these health plans. And they include in-home supportive services, the Multipurpose Senior Services Program, CBAS, Community-Based Adult Services, which is California's adult day health care system, and long-term care skilled nursing services. Next slide, please. Now, coincidentally, AIS happens to operate 2 of these long-term services and support programs. We operate the in-home supportive services program that provides domestic and personal care services to over 25,000 low-income seniors and persons with disabilities. Now, we've executed a memorandum of understanding with each of these health plans to deliver the in-home supportive services program to their members. We also have been the Multipurpose Senior Services Program, or MSSP program site for over 20 years in San Diego County. And this program is a care management program that arranges, pays for, and coordinates important services for clients to prevent avoidable nursing home placements. Now, we executed a contract, a revenue agreement, with each of these health plans to operate that program. Now, in addition, there is a requirement for the health plans to coordinate behavioral health services, and those services are under our county umbrella as well, and they now have an MOU to work together collaboratively to ensure behavioral health needs of the managed health plan members is met. Next slide, please. So beyond this required partnership under the Coordinated Care Initiative between AIS and the health plans, there are many long-term services and service providers in our community, as well as AIS, that are really well positioned and have been actively seeking opportunities to partner with, on a financial basis, the managed health plans to deliver additional what's called care plan option services. It was the opportunity and request from hospitals that were participating in the community-based care transitions program and these 5 managed health plans for assistance in connecting them with the long-term services and supports, the home and community-based services, that we began thinking about how we might make that happen. So we started to think about, what about establishing a community-based brokerage that could provide access to high-quality home and community-based services through a network? And a single referral entity would be a point of contact and the hub to receive requests for services and then link those services for those complex individuals. You see, we know for a fact that home and community-based services reduce the overall per-patient health care cost. That's been demonstrated nationally. We know it reduces emergency room visits. We know that it prevents hospitalizations and readmissions, as we've demonstrated through the Community-Based Care Transitions Program. And we also know that these home and community-based services reduce out-of-home placements and improve HEDIS measures for healthcare providers. We also figured that if we established a brokerage, perhaps a variety of home and community-based services who are not able to individually contract with health plans and hospitals and other payers would have the opportunity to deliver their very specialized services to people in the community that needed those services beyond their normal referral and business practices. Next slide, please. So here's how we envisioned a brokerage might work. You see, it begins with a call to a single entity. That call would likely come from a healthcare provider or a payer. They have specific needs for their members or their patients. They request for those members to be connected to specific services and supports that are needed. Now, that central hub, that brokerage, could serve the function of simply reaching out into the community and connecting the requester with the home and community-based service providers, or it could serve as a hub to also provide assessment, care planning, and up to 30 days of short-term care coordination. So what's the benefit of using this centralized hub? Well, all of those home and community-based service providers that served that member or patient would invoice the brokerage. Their individual invoices would be paid by the brokerage, but the brokerage, serving as the fiscal intermediary, would then only submit one invoice to the requesting healthcare payer or provider, thus reducing their administrative overheads as well as the time spent by their clinicians trying to reach out into the community and arrange for services for these high-risk individuals. Next slide, please. Now, as you've heard, AIS has really served as that neutral and trusted partners with both healthcare and home and community-based service providers in our county for many, many years. So it really wasn't surprising as our community-based care transitions program matured and San Diego was selected as one of the counties to implement the Coordinated Care Initiative, that both of these groups of providers reached out to us for assistance in helping bridge these two distinct systems of care. So internally, we started to think about how we might leverage our Aging and Disability Resource Connection, which already serves as that no wrong door access in San Diego for information and assistance and linkage to home and community-based services, how we might build on that infrastructure and create a brokerage. AIS already has a large number of contracts already in place with many of these home and community-based service providers to provide services for our many programs, including adult protective services and our case management programs. And those contracts, we figured, could easily be expanded so that any home and community-based services that met the qualifications of providing high-quality services could be included in the network of providers. So we brought an internal team within AIS together, and we started to analyze what this concept might look like if it were built by an area agency on aging, if it were built perhaps on the infrastructure or of an ADRC. You see, the need had already been clearly identified to us by our community of healthcare provider payers and our community of home and community-based services. So we knew there was a need. So we started to focus on what a viable model might look like and what would it take to really implement such a model. And that analysis led to the development of two potential models for consideration. One, as I spoke about, would just connect the requester to the service providers and then streamline the fiscal process. The second model would actually bring into play expertise of older adults and persons with disabilities by providing an assessment, care planning, and short-term service coordination. So at that point, we would also be bringing in options counseling. Next slide, please. So after we completed this analysis, we realized that internally we lacked the expertise to address some of the really important considerations, including data sharing, legal implications, and risk management. So the timing for taking the brokerage conversation to the next level coincided perfectly with AIS being awarded a grant from the SCAN Foundation for the Long-Term Care Integration Project to serve as the regional coalition for San Diego County to support the transformation of long-term services and supports in California. Now, for those of you who are not familiar with the SCAN Foundation, they're focused on advancing a coordinated and easily navigated system of high-quality services for older adults that preserve dignity and independence. So the grant that we were awarded from the SCAN Foundation allowed us to complete a deeper analysis of the issues and considerations that were uncovered during our initial AIS analysis. Next slide, please. So with funding from the SCAN Foundation grant, we engaged collaborative consulting to convene a team of executive-level thought leaders from our healthcare and home and community-based services community to provide guidance to design and operate a home and community-based services brokerage. Now, the goal of the design team was to consider organizational structures and operations that would facilitate access for healthcare payers and providers to high-quality home and community-based service providers, and to support the home and community-based service providers by taking away the cumbersome relationship or responsibility of establishing relationships and contracts with individual health plans, hospitals, IPAs, accountable care organizations, and other healthcare entities. Next slide, please. So the design team was charged with creating a guide that could be used as a reference for any community that might be interested in improving access to home and community-based services. So the guide was meant to be a conceptual roadmap rather than a prescriptive model. The design team used the AIS analysis as a point of reference and then identified considerations for both the development and implementation of a brokerage by any lead entity. So the consultants provided guidance to the team on different legal structures and advised the group on similar interventions that were in progress or had already been implemented across the country. So I think I've provided sufficient background now to turn this presentation over to Renee Sherrill, who's going to walk you through the actual guide.
Thank you, Brenda. Next, you've got it. I trust that you've all received an electronic copy of the Brokerage Design Guide. I'll be walking through much of that right now. For the guide and the San Diego County case study, we use 6 steps for the design process, and we adapted many of these concepts from Discovery-Driven Growth by Rita McGrath and Ian McMillan, published by Harvard Business Press. It's a book that talks about the best ways to go, or some great ways to go about developing something when you have a high level of uncertainty. And in this case, we did have a high level of uncertainty. So I'll be walking through the case study in San Diego to demonstrate this process in the guide. If you have the guide in front of you, you might turn to Appendix B, page B1. Next slide. So the first step is to design the service delivery model. And in order to do that, you need to look at the existing state. And Brenda did a great job of describing the background here in the county of San Diego. One of the first things we asked ourselves was, what is the need that we are primarily trying to address? And Brenda described it very well. There is a need to access a wide array of home and community-based services to improve healthcare outcomes and reduce costs. And healthcare providers really don't always have the expertise in home and community-based services. There's also a lack of financial alignment between health and community-based support. Funding is siloed, and there's more funding available for healthcare than home and community-based services. So we identified the need, then we asked ourselves, who are the customers who would be the primary users? And for us, that would be healthcare providers and payers, consumers, their families and caregivers, and then the high-risk medically and socially complex patients themselves. We then asked who else might be interested or benefit. And of course, the home and community-based service providers would be interested. Our local Aging and Disability Resource Connection, the Administration for Community Living, California Department of Aging, California Department of Healthcare Services, California Health and Human Services, and the Centers for Medicare and Medicaid Services. We then asked ourselves, okay, well, how large is the population in need of home and community-based services? And in San Diego County, 17% of the population is over the age of 60. We have approximately 45,000 with one or more disabilities, and 189,000 in San Diego County in 2010 had 3 or more chronic conditions, so we define that as medically complex. We then looked at the current environment. What are some changes or new developments that we might capitalize upon for the brokerage? Well, there are new financial models, including incentives for accountable care organizations, new CPT claiming codes to help address the funding issues, the community coordinated care initiative and community-based care transitions program that Brenda spoke about earlier, CMMI innovation projects, the DSNPs are already providing care coordination, the Affordable Care Act has growth in new populations. There's a growing desire for community knowledge about palliative care. We have isolated seniors aging in place, and there are many best practices occurring outside of San Diego County. So once we identified the need and the current environment, we looked at the unit of service. And when you're looking at the unit of service, that's a really interesting thing. You can end up with some real innovative concepts if you think about how you're going to bill. It can really change how you deliver service. For example, I don't know how many of you have been hearing about Taylor Swift, but she's actually moving from streaming and having people pay per listen to she's stopping that and moving to actually buying her album. So how you deliver that service is different. So we asked ourselves, how might we charge for brokerage services? We could charge per hour, just a flat rate. That would require robust tracking, though, and we'd have to be able to prove the hours spent. We could charge per referral, but that could be high risk because one client could require connections to up to 10 home and community-based service providers, while the other client only needed connections to one. And if we received a lot of high-need folks, we might not be able to that might not be cost-effective. We could charge per service access. It would be a flat rate. We could do fee-for-service. We could do a capitated rate, which is very high risk. We could do a sliding scale based upon the volume of the client, or we could share the risk and benefit with our partners. So in our case, we didn't come up with anything innovative, but we did look through different ways that we might charge. Then we looked at our service delivery model. And Brenda briefly described the two models that we thought about. We thought about referral only, and we just created a process map that's right in your guide there on page B4 if you have it in front of you. So we outlined step by step what it would look like when the healthcare provider called the brokerage, all the way through contracting and the fiscal reimbursement. We did that for referral only, and then we also did it for the assessment and short-term service coordinations models. Then, after we designed those models, we stepped back and said, okay, are these models going to add value against the existing state? So we compared Model A to Model B and the existing state of uncoordinated network of providers in 4 areas. We looked at the speed of the service, the cost of the service, availability of service, and quality. And we had no data at this point. Everything's theoretical, So we compared the potential value of the two models against the current state relative to one another, since there is no data. So looking at speed, one call from the provider would link the provider payer and the client to multiple services for the referred individual. So there was no need for the healthcare provider or payer to track down providers. That was the same in Model A, referral only, as short-term service coordination. In addition, the assessment and short-term service coordination added potential identification of additional needs. If the healthcare provider is focusing on health, the brokerage might offer additional services that might help the client. There would also be ongoing coordination and follow-up. In the existing state, the healthcare provider or payer would have to find the resources, make multiple calls, confirm with the patient, provide post-service follow-up when possible, and that's not always possible, and they wouldn't necessarily assess for needs outside of medical services. So when comparing the two potential models against the existing state when it comes to speed of access, the brokerage, both models were better. They weren't duplicative, and they weren't worse than the existing state. Moving on to the cost of the service, in Model A referral only, staffing costs are similar to case management staff, but a little bit lower. In Model B, it would be case management staff costs. And in the existing state, oftentimes medical staff time is used for service coordination. And there are higher healthcare costs due to increased admissions and readmissions, ER visits, etc. Some physicians are being paid for very short-term health-related, not social services, care and transition for patients post-hospital discharge. Also, many contracts, the cost of accessing many contracts and processing the invoices would be there. So the cost of service for models A and B were definitely better than the current state. Looking at availability, one call in models A and B connects the client to multiple resources. In the existing state, the providers aren't always aware or understand the home and community-based services. So the availability is much higher with the brokerage. When you look at quality, in Model A, referral only, knowledgeable referral staff would be helping the client. There'd be high-quality contracts requirements related to service provision, and there would be potential provider screening, and there would also potentially be an IT data infrastructure. When you look at assessment and short-term service coordination model, in addition to Model A, there would be high-quality service coordination by experienced staff. In the existing state, high-paid healthcare professionals are working outside their areas of expertise, being pulled away from their clinical work. So when you're looking at quality, the brokerage was better again. So in all four areas, looking at overall value of the potential models, the brokerage was better. And at this point, we've done a real quick and dirty assessment and not spent money other than staff time. So we're not into implementation yet. We're just looking at value added. Then we moved on from the customer experience perspective and did the same type of assessment. We looked at 5 areas: awareness of service, access to service, use of service, payment, and discontinuance of the service relationship. In this case, that was when the payer ceases the contractual relationship with the service provider. So looking at awareness, in Model A, the brokerage would provide education to healthcare providers about the value of home and community-based services, and they would also provide information about what home and community-based services are available. Additionally, they would provide education to consumers in the community. That would be in the referral only as well as the assessment and short-term service coordination. In the existing state, healthcare providers and payers have little awareness of home and community-based services network, the fees and the services and the geographic coverage. So in awareness of service, the brokerage was better than the existing state. When we were looking at access, you have almost immediate access, and that's similar to the speed where we were looking at in the earlier assessment. For both models A and B, there would be delays related to having to look up providers and contact multiple providers in the existing state. So the brokerage was better again. In looking at use of service, a single call from the provider connects their clients to multiple resources in both models A and B. And in the existing state, the provider has to make multiple calls, so the use is easier. For payment, as Brenda said, a single invoice per month for a provider for all of their clients for all of the services is a huge savings over having to be invoiced for every service for every client. In addition, contract monitoring would be provided and contracting. There would be one contract with a brokerage rather than a contract with each provider. When you're looking at discontinuance of the relationship, there would be a single contract or no contract for the brokerage, where under the existing state you would have multiple contracts to have to terminate. So from the customer experience, in looking at the business case, both models of the brokerage was better than the existing state. So once we did that, we stepped back and looked at performance metrics, and we asked ourselves in 5 key areas, how do we anticipate performance to be? We looked at reduction in per-patient healthcare cost overall, reduction in ER utilization, reduction in hospitalizations and readmissions, and reduction in out-of-home placements, and improved HEDIS measures for the population served. So we compared Model A with Model B with the existing state. Again, there is no data at this point, so we compared them relative to one another, and we asked ourselves, do we expect it to perform better, worse, or the same? And for all 5 metrics, the existing state we anticipated would score the lowest, compared to Model A, which was referral only, and we assessed that as medium, and Model B, where we add short-term service coordination and assessment, we anticipated that it would score the best. All of this work at this point we are doing on our own. We did this before we received the contractor and the design team. Once we got the design team in, they looked at all of this and gave us feedback and enhanced it. In addition, when it came to the metrics, they identified potential additional metrics, and in your brokerage design guide, there's a list. A table is included. Once we did this, we stepped back again, and at a high level, we asked ourselves, okay, do the brokerage models, although it's promising, do they provide a significantly higher level of service so that enough customers will really care? Does it change the cost-benefit ratio for the customer? And does it change the standards that customers use to judge value? And in all 3 cases, we said absolutely yes. It's a significantly higher level of service because currently there is no single access to the full array of services. It changes the cost-benefit ratio, because, especially for those healthcare providers or payers that are required to demonstrate care coordination and reduce healthcare costs. Also, for those that are not mandated to provide this, we anticipate a positive return on investment. We also anticipate, and the data is showing, that home and community-based services reduce readmissions and the related penalties and the length of office visits, length of stay, and intensity of care needs. So that's our business case, and at this point we haven't spent very much money at all. We've done a good assessment, we've outlined our model, and we think the models are going to add significant value. Next slide, please. So I camped out on that slide. That's the bulk of our time. The next slides we'll go through fairly quickly. Step 2 is to identify the requirements, and here's where our design team really helped us. We created a little worksheet for startup requirements, and that's in your guide. And for each step in the service delivery process, we've asked ourselves what needs to be in place and what do we need to do to get it in place. After that, we looked at workforce considerations. What are some considerations for staffing levels? volumes might fluctuate. There might be anticipated turnaround times. There might be contractual requirements related to turnaround times. There might be a high level of follow-up, and we might want to be talking about the capacity. So we identified strategies for flexible staffing. We needed to be able to quickly adapt to the ebb and flow, and you can see in the design guide there's a list of ideas for making sure your staffing is flexible. We also identified the required employee skill sets. So in the guide you'll see it's a job skills list, skills needed and educational requirements. We looked at how we might manage the processes better and cross-train. Then we moved on to legal and contracting requirements, looking at legal and liability considerations, such as who's responsible to follow up, if the service is inadequate to meet the outcomes, and identifying what to do if something goes wrong. What would the exposure be for the brokerage might carry? We looked at legal documentation requirements for clients, home and community-based service providers, referral sources, payers, and healthcare providers. We needed to identify insurance requirements, service provider accountability, and regulatory oversight. Then we asked ourselves, what would be contracting considerations? We identified some general considerations, some challenges that we might need to determine how the brokerage members will ensure sufficient volumes. Reimbursement would be the biggest concern, and we looked at the content required for contracting, and we have a really complete list, I think, there related to contract content. We then moved on to talk about data sharing considerations. One of the things that was mentioned quite a bit was the need for an electronic centralized system. And along with that came a whole slew of considerations around challenges for delivering data, differing levels of provider sophistication, the difficulty to establish that, the importance of it, the extent of data sharing. The HIPAA obviously came up. Moving on to confidentiality considerations, definitely related to HIPAA compliance and business sharing, the needs for business associate agreements, methods to share that information seamlessly while still protecting patient confidentiality, levels of access to records and liability for breaches. So we looked at a lot of different things. We moved on to risk management, and our team identified a lot of risks. And again, identified some potential mitigations. That is in the guide on page B16. So we had a great team, very knowledgeable, provided a lot of information for us. Along the way, we were documenting unknowns, and that's a critical step. As you bring people together and have the discussions, they're very valuable and fruitful, and you identify a tremendous amount of unknowns. So it's really important to track those throughout the process. Next slide, please. So then we moved on to assess viability. That's a critical step needed. Early on, we assessed whether or not it would be valuable. Now we need to look at, is it going to be viable? So the first step is doing a market analysis of community readiness. We have not completed that in our county, but we have identified how we might go about that. We're looking at using the U.S. Census American Community Survey from 2008 to 2015. It has 5-year estimates, and it includes population data with disability breakouts by those with hearing and vision, cognitive, ambulatory, self-care, or independent living difficulties. We want to take a look at that and overlay it with local home and community-based service provider information, and do that on GIS mapping so we can get a sense of, okay, here's the potential need, and in the specific geographical areas, here's the potential capacity. Once you do a market analysis, it's important, we did an environmental scan of current solutions. So rather than try to recreate the wheel, what's out there that's already working? And our consultant did this. They contacted 3 different organizations. They contacted Direction Home Ohio. This is a cooperative of in-home and care transition specialists. Their legal structure is an LLC. They're for benefit, for profit. They're owned by 12 AAAs, each of whom are members, or owners of the LLC, and their board is made up of the CEO of each AAA. They also contacted the Coordinated Care Alliance. Their legal structure it's in Illinois. It's comprised of care coordination units throughout Illinois. They have a network of 25 members. Their legal structure is a corporation. They're a 501c3, not-for-profit, and their board they have a representative from each member organization. The third organization they spoke with was San Francisco Network of Aging and Disability Community-Based Organizations. It's a county organization selected by ACL to receive targeted technical assistance to build business capacity. They are in the process of forming, and they're looking at a structure similar to an MSO. Additionally, you'll need to look at financial viability. And again, there's no need to recreate the wheel there. We have 2 links in the Brokerage Design Guide. The SCAN Foundation has a budget and financial planning tool that's very robust, along with the Aging and Disability Resource Connection Service Cost Tool. And again, throughout this step of assessing viability, it's very critical that you document unknowns. Next slide, please. So the 4th step is to look at your legal business model. And our consultant again did some research here for us. They identified legal entities, tax status exemption, and organizational structure. And the brokerage guide, I won't go through detail there, but they identified, they did some explanation of a limited liability company, a type of limited liability called an L3C, and an S corporation. They identified pros and cons of the LLC, pros and cons of the S corporation, a little brief description about tax exemption and 501c3, and then the differences between the 501c3 and the L3C, which is a kind of a combo of for-profit and not-for-profit. Additionally, a AAA or an ADRC could operate a brokerage. Next slide, please. So steps 5 and 6 are the last 2 steps, and that's where you take a look at all of the unknowns that you've been documenting, and you identify which of those uncertainties are make or break. And from those make or breaks, which of them are going to be fairly quickly resolvable or inexpensively resolved. And put those first, and structure your, create a plan to resolve those unknowns so that you can determine whether or not it's a viable process for you at the lowest investment. The next step is to look at a marketing strategy. And in the design guide on page B19, our design team came up with a list of target audiences and key messages for each of those target audiences, grouped by healthcare provider, provider-payer, payer, home and community-based service provider, individuals and caregivers, and others. And once you identify your marketing strategy, the final step is to develop an implementation plan. And our design team came up with some ideas, especially of piloting, considering piloting a small brokerage with a single health plan to start small and see if it works. Next slide. So our design guide, we submitted it to the SCAN Foundation. We posted it to the Long-Term Care Integration Project website, and we're currently distributing widely for communities interested in improving home and community-based services access. Next slide. So what we learned, for us it was very exciting. Early on, we learned quite quickly that there is strong support in San Diego County for home and community-based services brokerage. We do need to assess the potential demand and capacity to meet that demand. So that's where we are for now. Next slide, please.
Well, thanks so much for all of you for listening in, and I hope you found value in the process that we went through here in San Diego to really do some analysis of how do we improve access to home and community-based services and support our community of healthcare payers and providers in this very new delivery system and system of accountability. You know, we did find this process to be very valuable and insightful. It created even stronger relationships between these two distinct systems of care. And it certainly gave us a lot to think about and a lot to consider before anything moves forward. We're at the process now of really going back and trying to answer many of those unknowns that you heard from Renee, because in every step of the process we found that there were unknowns that needed to be answered satisfactorily before really moving forward. We also are really in the process of talking with our community to find out what is the interest of various entities in actually serving in some sort of a brokerage capacity and under what structure they might be interested in doing so. Internally at AIS, we're also considering, because of our status in the community, is this something that would benefit our community if we were to take on through our Aging and Disability Resource Connection. So I believe we have a few minutes left for questions, and Renee and I are happy to try to answer any that you may have.
Excellent. Thank you so much, Brenda and Renee. So now we will open up for Q&A. Operator, if you could please provide instructions for asking a question through the audio line.
Thank you. We will now begin the question and answer session. If you'd like to ask a question, please press star 1 and record your name clearly.
Okay, thank you. While we're waiting for questions to come in, I received a couple of questions via chat concerning accessing the guide that Renee was just speaking to, and you can download that guide on the San Diego Long-Term Care Integration Project, and I have posted a link to that site in the chat box. If you don't see it there, that web address is www.sd.l as in long, T as in term, C as in care, I as in integration, P as in project.org. So that is www.sdltcip.org, and you can scroll down towards the bottom of that page and you can access the guide there. Checking to see if we have questions. I'm not showing other questions in chat. Operator, have we had questions come in through the audio line?
We have no questions at this time.
Okay, thank you. Okay, well, I just had a question come in via the chat. So the question is, what are your findings so far and how the costs of the brokerage are covered?
I'm not sure if the question is referring to staffing. As I said, we certainly have not established a brokerage here in San Diego County. We're still very much in the investigative stage, but we have decided, based on our analysis internally, that Model B, where there's a level of assessment and care planning as well as short-term coordination, would be of great value to our community. And so our staffing would include social workers that are experienced with the community of home and community-based services and probably most likely come from a background of care management.
Okay, thank you. Let's see, I have another question. What would you list as high-quality standards? What kinds of home and community-based services do you anticipate payers would want to pay for? And are there other than the assessment and care planning?
Well, you know, as far as high-quality providers, those would be entities that provide services that have received good customer satisfaction rating, as well as they meet the qualification standards. So, for example, if the service delivery requires a registered nurse, that organization demonstrate that they have staff that have that required licensure. So it really would be a matter of meeting the insurance requirements and the liability requirements that would be necessary to ensure the good quality.
Also, our contracts have performance requirements. We have a lot of contracts for home and community-based services right now. And in the brokerage guide, on the very last page on B12, to answer the second part of your question, we do have a list of home and community-based services support types of needs developed by our design team. Great, thank you. Let's see. I'm not showing any other questions in the chat. Operator, are there questions on the audio line?
We have no questions.
Okay, thank you. Just wanted to double check. Okay. Well, since I'm not showing any other questions, I wanted to thank you so much to our speakers for participating today and sharing all of that wonderful information. Again, if you have any trouble finding the guide or other questions that you think of after we conclude the webinar, please feel free to email them to me. My email address is Lauren, Lauren, Solkowski, that's S as in Sam, OLKOWSKI, at acl.hhs.gov. So please email me your questions or comments, and we'll respond to you. Okay, so just thank you again to Brenda and Renee, and I think we will conclude our webinar for today.
Well, thank you, and you also have our contact information, both mine and Renee's, on the final slide, and feel free to reach out to us directly with questions. Be happy to help you out.
Excellent. Thank you both so much, and everyone enjoy your day.
Thank you.
This concludes today's conference. Please disconnect at this time.